Okay, I think we're going to get started. People are still trickling in, but I want to get going because we have two speakers and a topic dear to my heart. I want to start again with the land acknowledgement. So Ottawa is built on the unceded Algonquin and Anishinaabe territory, and the peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. So today we have two presenters, Dr. Erika Bariciak and Dr. Carolina Jimenez, and they are speaking about pull up a stool and let's talk about biliary atresia screening. So they're talking about biliary atresia screening of all newborns in the province. It's one of the newest not so new anymore, but point of care screens that all babies are offered, all families are offered in the province. And as those who know me, that was my previous life, and this was a particularly proud one in terms of being again world leaders in moving the envelope and early detection of things that we can really make a difference of in neonates. So with that, I'll hand it over to the people who know about it and can tell you all about it. So Carolina has been a member of the Department of Peds for nearly 20 years. We're all we're all getting a bit older, eh? Yeah. She completed her pediatrics training in Costa Rica and pediatric GI liver subspecialty training at Hospital for Sick Children. She's currently the director of the liver clinic at CHEO, GI division chief, and chair of the Canadian Pediatric Hepatology Research Group. And Dr. Erika Bariciak is an associate professor of pediatrics at the University of Ottawa's Faculty of Medicine and a neonatologist at CHEO and the TOH General Campus. She's also an adjunct professor in computer and systems engineering at Carleton University and is the medical lead at Newborn Screening Ontario, really overseeing a lot of the point of care screening medically for the province. So thanks, and hand it over to you.
Thank you. Good morning, everyone. Thank you for waking up so early and being here on site and on the screen. So we have no conflict of interests to declare. And then our aims are to review the epidemiology, diagnosis and treatment and outcomes. So biliary atresia, that'll be my part. And Dr. Brisiak is going to talk about the biliary atresia screening in Ontario. So with this, we're trying to disseminate this particular condition and the way that we should be screening for these patients for early detection. So I'm going to start with a case presentation because it's always important to kind of understand this condition. So this patient came to CHEO. It's a real case. It's a 2-month-old child that was seen by the family physician at a well baby visit. Parents reported that he was jaundiced since birth and he was exclusively breastfed. The baby was growing nicely, no problems at all. And he also had a history of right aortic arc. So the day of the assessment, that's when they saw that the stools were pale. On physical exam, as I mentioned, he was physically well, except that he didn't have any hepatosplenomegaly or any dysmorphic features. As you can see here, his blood work revealed elevated conjugate direct bilirubin and abnormally elevated liver function tests. Please note the gamma GT is significantly elevated. So investigations proceeded and he had abdominal ultrasound, which show a contracted gallbladder, which we often get on ultrasounds. We don't know if it's because the baby was fed and then the gallbladder was already contracted, or is it like a true small gallbladder. So he did have a HIDA scan and there was no gut activity at 24 hours. So at day 5, he had a liver biopsy. After admission, they did a liver biopsy and they could not do the cholangiography because they could not see the gallbladder at the time. So his biopsy was consistent with biliary atresia, and he underwent Kasai operation at age 75 days of life. But the liver was already cirrhotic, and the cholangiography intraoperatively showed biliary atresia, and he underwent Kasai. So an overview of biliary atresia. So we know biliary atresia is progressive. It essentially is an obstruction of the cholangiocyte or the bile ducts. It may be a neonatal onset, but it can also start prenatally in some cases. So this condition is the main indication or the main indication for liver transplantation, as this disease even progresses after a successful Kasai operation. And very often it's isolated, but there's about 8% of the cases that may have other congenital anomalies like cardiovascular conditions, kidney, polysplenia, or asplenia. So there are several forms, as I mentioned. The non-syndromic one is the most common one, up to 90% of the cases. And the syndromic one, as I said, is called biliary atresia splenic malformation because that's kind of the more prevalent anomaly, is having asplenia or polysplenia. And then there's a third form that's called cystic, which is, in the end, they all behave the same way and they need the same treatment. And it's very rare, that cystic biliary atresia. So this is just a diagram to show you how the normal biliary atresia look and how it looks in biliary atresia. So these are the different types of biliary atresia. And as I mentioned, the general approach is similar. Oh, this is going by itself. So this is a disease that is considered a rare disease because the prevalence is like 1 in 20,000, for example, in Canada, but in other countries like Taiwan and there is a Polynesia Islands, it's quite high. The prevalence is quite high. So you can see on this map a study we did in a few years ago showing the prevalence of biliary atresia on the planet. So what causes biliary atresia? No one really knows. It's really something that could be multifactorial. So there's a theory behind a possible genetic predisposition. Perhaps in utero something happens to the fetus, like perhaps anomalies on the arterial circulation or something that happens in utero that we haven't been able to identify. Could this be immune related? So there's some studies that show that there's different cytokines, different subtypes of inflammatory markers that could be present in kids with biliary atresia, which in some way has been a kind of a reason why in some centers they've tried treating biliary atresia with corticosteroids, which, and in the end, it didn't show any the studies haven't shown any significant improvement on that, but that is another theory why these kids may present with biliary atresia. So again, another theory is the bile duct injury with impaired bile flow, and these other potential factors. There's also the because biliary atresia has some seasonality. You have patients that come in clusters, 3 in a month, and then you have a whole year that nobody comes, right? So there is a question about a viral infection. Could this be related to a toxic or environmental factors? So all to say that nobody really knows. It could be multifactorial. As I mentioned, viral trigger, some viruses, as mentioned here, rotavirus, reoviruses, CMV, papillomaviruses have been implicated or have been found on the tissue of babies with biliary atresia. As I mentioned, immune factors, different mechanisms have been studied and proposed, and particularly in these babies that may have an immature immune system, this autoimmune susceptibility would kind of cause this progression of liver disease. So essentially, the first step is to suspect biliary atresia to establish the diagnosis. So clay color stools and jaundice at 2 weeks of age should make you suspect of biliary atresia, regardless of how the baby looks, if the baby looks well. Some babies may even have pigmented stools over time, and then just in the end, like this case that I presented, may have as a last presentation the clay color stools. But more often, babies will have acolic stools right from the beginning at 2 or 3 weeks. So the direct bilirubin, in some places they do conjugated bilirubin, remains the primary test to determine whether somebody needs further investigations for biliary atresia or any other liver disease. So the ultrasound is an easy thing to do. It's available everywhere. So when somebody is suspecting any liver anomalies, it's indicated to do an abdominal ultrasound. So it not only detects the presence of a small gallbladder, but also potential structural anomalies like colorectal cysts or any other thing that could be causing this obstruction. So there is a sign on an ultrasound that's kind of classic in biliary atresia called the triangular cord sign. And I'll see if I have an image, but usually the radiologists, when they observe this, they report it. So keep an eye on that. So once you have a high index of suspicion, then an intraoperative cholangiogram can be done. And what they do in the OR, they inject the contrast and they see whether the dye goes up to the liver, and if it doesn't go, then you know it's biliary atresia. This can be done also by interventional radiology, a percutaneous cholangiography. As in this particular case I presented, they weren't able to do it because they couldn't see the gallbladder, and so you can imagine passing a needle all the way through the liver going to the gallbladder without seeing a proper gallbladder. So, but very often they would do a liver biopsy at the same time of the cholangiography under the same anesthetic, so that's really helpful. We're lucky that we have our interventional radiologists here that are trained to do that. So the next step is to do the Kasai or this is the primary treatment for biliary atresia. So it's been said that the Kasai operation is essentially a palliative treatment because most kids in the end are going to need a liver transplant, but that will delay the timing of transplantation or may not need it. So we have, in hepatology, we have this rule of the 1/3. So you have 1/3 of the patients will go straight to transplant because the Kasai didn't work immediately or because they presented too late. There's no even a room to do a Kasai. They're cirrhotic. Another third of patients will do very well post-Kasai, but will need eventually a transplant. And 1/3 of the patients will graduate at 18 without needing a Kasai. So the whole idea is to reestablish the bile flow so that the bile and all the subproducts of the bile acids, etc., are not contributing to this progressive liver disease. Some babies, even when they have a working Kasai, as I mentioned before. So what do you call working Kasai? A working Kasai is that the outcomes are by 3 months you have a relatively normal bilirubin and pigmented stools. See, beyond 3 months, if your bilirubin is still high, the Kasai didn't work. Okay, so that's essentially how we assess the outcomes. So this is just a diagram on how the biliary scan looks. So you can see all these the liver images. There is no gut activity at all. So what you expect is that they inject the contrast intravenously, and then they follow the scan as this contrast is uptaken on the liver. You expect that the bile will flow. The downside of this is that it may delay the diagnosis, so we can skip that step. So sometimes you go straight for a liver biopsy or intraoperative cholangiography, and just to expedite the treatment. So some conditions that can give you a positive HIDA scan are other cholestatic liver disease, like Alagille syndrome, like PFIC, for example, which is another condition that presents with cholestasis, and even TPN cholestasis can give you something like this. So essentially, this is helpful if it drains, because then it's not biliary atresia, right? So liver biopsy will show Bile plugs, as you can see here, a lot of proliferation of inflammatory cells. You don't see, so sometimes in biliary atresia, you see what's called bile duct proliferation. It's because the liver is trying to create new bile ducts so that the bile drains, right? So you see on the liver biopsy a bunch of excessive bile ducts, but they're immature and they're not working because there is a blockage downstream. But that's classic for biliary atresia. And the other thing is, you may see this is a stain specifically directed to fibrosis. So this is called trichrome stain, and you can see that some cases may have already nodular appearance of the liver, which is essentially cirrhosis, and this is a lot of fibrous tissue, even in a neonate of a 1-month-old, right? So these babies are, they have this chronic liver disease. This is a cholangiography, so you can see how a normal biliary tree looks like, and here they injected, there's nothing, basically. So it's confirming the diagnosis of biliary atresia. So this is just a diagram of what the Kasai or hepatoportoenterostomy surgery is. So essentially, what they do, the surgeons, this sounds very simplistic, but in real life, it probably is difficult because, it's in a small baby having too many hands, and it has to be open surgery. It cannot be laparoscopically. So what they do, they dissect the hepatic plate here until they see bile coming through. And then they anastomose a piece of jejunum up there to reestablish that bile flow. And the other areas here, stomach, duodenum, that remains intact, but then they reanastomose downstream. All right, so that's essentially what the Kasai operation is, obviously invented by Dr. Kasai. So this is the primary treatment strategy, and the when you don't have proper bile drain, then that's when the situation evolves, and the child will need liver transplant eventually. So these patients pre and post Kasai operation, our key is to keep them in good shape, well nourished, with a lot of fat soluble vitamin supplements. We work together with dietitians, and if by 3 months they haven't decreased the bilirubin, I send them to see kids for assessment for liver transplant. So again, it depends on when you do the Kasai operation. That's how the outcomes are going to be. So in Canada, a study from 2006, 2009, actually, showed that the time of Kasai operation was about 55 days. So we want this to be earlier as we can, because if you do it earlier, then about 70% of patients will reestablish the bile flow. If you do it later, then too late. It's not going to happen because it's too cirrhotic. So just to maybe a few words on outcomes. Essentially, in the later you do it, the more chances the child is going to need a liver transplant. If the Kasai operation is not done or nothing is done, these kids will die by the age of 2. And they have the classic features of anybody with cirrhosis: hyperammonemia, encephalopathy, ascites, all of the classic features. The only caveat is these kids will have impaired growth because of malnutrition. And so when you are preparing for transplantation, you want to optimize all of these aspects so that they're in good shape for transplant. So the more we delay the transplant, the better for the patient in terms of size and difficulty of the technical aspect of the transplant surgery. In addition to that, if you do a transplant earlier in life, these kids are not going to have all their vaccinations. They will have more risk of EBV infection, which is something that we try to avoid. So usually by age 2 or age 3, most kids have been exposed to EBV, but if these babies are transplanted earlier, they haven't. So there's a high risk of primary EBV infection post-transplant on a child who's immune suppressed. That could be catastrophic because they can present with lymphoma-like features with the EBV. So this patient developed severe ascites the days after his Kasai. He did not respond to conventional therapy for ascites, like LASIK stuff, and he presented with severe hyponatremia, portal hypertension, and his wound opened up. So he was transferred to Sick Kids, and he had a liver transplant at age 4 months. So he's presently doing very well, except for, as I mentioned, post-transplant or transplant could be quite challenging because of the patient's size and the ratio of the donor, liver donor, the ratio size in terms of portal vein, arteries, and it may be challenging, and they can develop complications like portal vein stenosis or, artery occlusion. This child is doing well, thankfully. Just to finalize, because I know Erika is going to talk about this, we have different biomarkers that have come up in the literature. I'm going to let Erika talk about it, and I'll give you the floor.
Okay, thank you, Carolina. That was a nice intro and whirlwind tour through the complex disease of biliary atresia. So I'm going to talk next about how we can do better at helping these kids to have an optimal outcome through universal screening in the province of Ontario. So I'll cover why we need to screen for biliary atresia in our province, and then the evolution and performance of our program and some of the next steps that we're hoping to take. I think most people are aware of Newborn Screening Ontario, but as a reminder, we're the province's program to screen for rare but treatable disorders prior to symptom onset in all babies born in Ontario, Nunavut, and Newfoundland. And we screen for over 30 conditions. Most of those conditions on our screening panel are screened for through the dry blood spot or the heel prick test. And this ranges from metabolic disorders, endocrinopathies, hemoglobinopathies, some immune diseases, CF, SMA. And then we introduce some point of care testing. And so we screen for critical congenital heart disease through oxygen saturation testing. So saturation probe on the hand, right hand, and either lower limb prior to discharge from hospital or at around 24 hours of age if not born in hospital. We also screen for risk factors for permanent hearing loss, and this is done off of the dry blood spot test. And then in January of 2023, we rolled out biliary atresia screening. And this is our first at-home screening program. All of these other things happen within the context of healthcare. The lab for the province is housed out of CHEO, the Newborn Screening Ontario lab. And we pick up about 250 infants per year with one of these screened diseases, and that works out to be about 1 in 600 infants. So, should we screen for biliary atresia? Well, we heard that in Canada, we're not doing great at picking up this disorder within that 30 to 45 day window when we have best chance for best outcome of preserving that liver. And unfortunately, in Ontario, it's a little bit worse. So our median age at picking up biliary atresia is 62 days, and the median age at performing the Kasai is 66 days. Only 25% of babies are getting that Kasai in that under 45-day window. And unfortunately, almost 20% are getting it after the 90-day period where we know the outcomes are the worst. So we do have room to do better, and we need to pick these babies up earlier. So why is it so hard to pick them up? The first and main reason is that these babies seem well. They don't have significant symptoms even at the time of diagnosis, it's often just this prolonged jaundice. And jaundice is common in babies. Close to 80% of babies will have some level of jaundice. And so it's described as the yellow needle in the uniformly needle or yellow haystack. And, a lot of members of the public, parents, as well as healthcare practitioners aren't aware that persistent jaundice, longer than 2 weeks in term babies or 3 weeks in preterm babies, or pale stool can be a sign of potential liver disease. So a lot of families who have concerns about this, people will notice it in family photos, or other family members will notice the yellow dyes. They're often falsely reassured that, oh, you're still breastfeeding, or, this baby's otherwise fine, so we'll just watch it. And then the final reason is that most of these babies aren't seen by a primary care practitioner during that window of the symptom development. So we'll see them in the first week after birth, and then we'll see them again at the 2-month mark where they're starting their vaccine series. But in that critical time period, nobody is really having a look at them. So we need to find a way to help parents alert us if something's going on. To determine whether a disease or a condition meets criteria for a universal screening program where, we're applying a test to the entire asymptomatic population where most people are not going to have the disorder, we need to use very strict criteria. And the criteria that were developed by Wilson and Younger in the late 60s are still used today. And all of these criteria need to be met for a screening condition to be added to our panel. So the condition has to be an important health problem. There has to be an acceptable treatment for the patients who were diagnosed very early in the treatment or in the disease course. The early treatment needs to have a favorable prognosis. There needs to be a reliable screening test, and that screening test has to be acceptable to the general asymptomatic population. We need to understand the natural course of the disorder. The cost of case finding has to be in balance with the cost of caring for these patients on a whole. And then we need to have a strategy to determine, once we've diagnosed these conditions, which babies should or shouldn't be treated. And so for biliary atresia to be added to the screening panel, we went through newborn screening's very regimented, standardized process. So 2 Ontario hepatologists, and one of them is sitting here, Dr. Carolina Jimenez, and Dr. Vicky Ng from Sick Kids, nominated this condition. So we have on our website, we have a nomination form. Individuals or organizations can nominate a disorder. And then we have an advisory council at Newborn Screening Ontario that consists of a multidisciplinary team that will then review the nomination. If it looks like this is likely to meet most of those criteria, they'll assemble a task force and they'll do a full review. And that full review is a published literature review. We do an international landscape review of all of the screening programs around the world. We look at the treatments and tests that are available, and risk-benefit ratios for bringing this on. And if after that task force does the full review, the review is then presented back to the advisory council. And if the advisory council and the task force have agreed that this is recommended to add to our panel, the proposal is sent to the Ministry of Health for approval and funding. And so this process takes time. I think this all started in 2019, and it took about 4 years from the time that they, really started getting this ball rolling to the time where we were able to roll out the screening. So it's an involved process. We also needed to look at what were we going to do for our screening test. And so Carolina talked about some of these biomarkers that are out there for picking up biliary atresia. And these are the top 4. The SCC is the infant stool color card, which I'll talk to after this slide. But direct bilirubin, we know, is elevated in biliary atresia. And so there's a group out of Texas that have done extensive studies looking at the fact that when babies are diagnosed with biliary atresia, if you go back and look at birth, if somebody fractionated their bilirubin, like usually at birth and in the first kind of week or 2 of life, we're doing an unconjugated or a total bilirubin. We're not fractionating it out into the direct and the indirect component. But hospitals that do that, these babies have elevated direct bilirubins even at birth, after birth. And so this group has suggested we should be doing conjugated or direct bilirubins on every baby. However, a lot of these babies will have a transient cholestasis that kind of goes away by 2 weeks of age. So then you got to get them back at 2 weeks to do another one. And that's where on a population level, this kind of falls flat, because it's very, very hard once they go out into the community. Many of these families don't have primary care practitioners to get them back and do that repeat bilirubin. And so that, plus the fact that this is a blood draw, it's hard to get blood work in babies, it causes hemolysis, that changes the result. And we don't have a dried blood spot method. So we really like, the convenience of having one test on filter paper that comes here, and we can do a ton of testing on it. And so for this reason, it hasn't been one of the universal screening tests that have been adopted. This MMP7 is a proteinase that is a breakdown product of extracellular matrices. And in biliary atresia, when you have liver fibrosis, this product is released into the blood at very high levels. And so you can see on the chart here that has a great sensitivity and specificity. However, most of the studies that were validating it did it right when the babies were being diagnosed with biliary atresia, so a few months of age, not right at birth. There wasn't a dry blood spot assay available for it, so we looked beyond this one. And then finally, serum bile acids. These can be measured off a dried blood spot. You can see their sensitivity and specificity is not great, and there are, varying reference intervals for this. And so to improve that accuracy, you'd have to do a GGT, a blood draw, and look at the stool anyways. So we thought we'd look at an infant stool color card based system. The first color card was actually developed in Japan in the Tojichi Prefecture. And Dr. Akira Matsui took some photos of biliary atresia babies' poop and normal poop, put it on a card, and sent it out in their mother and child health handbook. They do have a 1-month baby visit, and they were able to bring that back, follow up, and they found that they were able to decrease the age at Kasai from 70 days to 60 days, and the transplant-free survival at 5 and 10 years was also significantly decreased by using the card. Then Taiwan, who are considered the gurus of the infant stool color card, they pioneered the national screening program approach of using the infant stool color card in 2002. Again, they have a 1-month well baby visit, and they took photos again of baby's stool. They validated these photos, and they have been showing for years now that it has excellent sensitivity, specificity, and positive predictive value. They were able to bring their Kasai age down from 60 days to 48 days, and impressively, they no longer have babies that are having their Kasai over 3 months of age. Really good 5-year post-Kasai native liver survival rates almost doubled with this program. So there were countries in Europe, South America, and in Canada in 2014 in BC that followed suit and introduced modifications of the infant stool color card screening. So BC published their first 2 years of their program, and were able to show that there was reasonable sensitivity and specificity, and this was very cost effective to use for screening their population. And this was actually rolled out by one hepatologist in the province. It was not through a screening program like ours, Dr. Rick Schreiber, who was able to do all of the education, all of the dissemination. He took all of the calls from all the families, and he was able to show that, of the 6 cases that were picked up in those first 2 years, people were using the card. In the first 3 or 4 cases, they actually had a good early diagnosis, age, and Kasai procedure performance. But the last few cases, unfortunately, were still delayed. And you can see here that the parents detected the pale stools. The problem was when they went to their general practitioners, they were falsely reassured, and investigations were delayed. And so these kids had delays in their treatment. Over time, they've worked on this, and it is now something that is much more something else that the public is aware of, the healthcare practitioners are aware of, and they have been able to decrease their liver transplant rate by 3% and the time at diagnosis by 13 days. So we said, the infant stool color card, it is. And we got permission from BC to modify their card, produce it in our 2 official languages. We got permission from Dr. Mei-Wei Cheng in Taiwan to use their exact validated images. And we rolled this out in January 2023. So the way that it works is families are given a card at the time of discharge from hospital, or from a birthing center, or they're given a card by their midwives, and they're asked to screen the stool every day at diaper change for the first month of life. On the card are instructions for how to contact us if they have any concerns. So they can call us. We have a 1-800-POOP-CHECK number. We have a dedicated email address. And then they can scan a QR code and get into our online portal where they can actually submit information directly to us. And then we have a team of triage nurses who will contact them back within 1 business day, and will do a telephone triage, mostly determining if there's any visible jaundice. We'll ask for pictures of the stool, and this is important because you'll see on an upcoming slide, we get calls for all kinds of things, and often the stool isn't as pale as the parents are thinking. And so we'll follow those stools with the family through submitted photos of the stools. If we agree that the stool is pale, that's considered a screen positive, and then we refer them for an outpatient director conjugated bilirubin, which is then directly tied with one of our 5 pediatric academic health science center hepatologists who will do the interpretation of it, decide if any follow-up needs to happen, and go from there. So the workflow here in Ottawa is, our nurses will page GI on call. They'll be notified that there's a screen positive. They'll be given the parents' contact information. Our nurse will then fax the consults to the admin in GI, who will arrange the outpatient blood work to be done. And cholestasis is defined as a direct or conjugated bili greater than 17 micromoles per liter. That'll trigger the baby having to come in for further investigations, as Dr. Carolina Jimenez alluded to in her talk. If it's sort of mid-range, it's under 17, but it's greater than 2, it could be that it's just on the rise. And so we're going to check it again in 3 to 5 days and see which way that's going. And if it's positive but under 2, as long as they have pale stool, we're going to keep an eye on that, and we'll probably repeat it in 2 weeks. And this is important not just for outpatients, but inpatients in hospital should also have their stools monitored. And so we have given cards to the pediatric floors and encouraged other hospitals within the province who admit babies in the first month of life to have those cards available. Often families won't think to bring their card when their baby's admitted. And it's really important for premature babies because they have a slightly higher risk of BA and they can present a little bit later. And so babies born under 37 weeks, we will ask that stool be monitored for 4 weeks or 1 month past their due date. Okay, so now we'll dive into how our program is doing. So we sent launch kits, which consist of a starter pack of infant stool color cards and little card holders and posters to educate about the program, as well as scripts for families to learn about the program, as well as to educate healthcare staff, to 214 submitter sites around the province. So these are all the sites where babies are born or cared for at birth. Within 6 months of our launch, all of our submitter sites were confirming distribution of the cards, and to date, we've screened over 300,000 infants. Our submitters say it's great resource for families, really easy to implement, and our families really appreciate it as well. They appreciate that they've got someone to call. We've got Margot here, one of our nurses, and she has lots of interesting conversations with families who are really just looking for best outcomes for their baby. And so we've got a team who can help, but the tool is also said to be very self-explanatory, and families are finding it easy to use. Now, given that this is a community-based screening program, we had to do a ton of education and information dissemination. So we did provincial webinars to our submitter sites, as well as midwifery, public health, and family practice locales. We also published an article in the CPSO members dialogue and sent information through various organizations' newsletters. We also had a social media campaign. So we hired a marketing company called National, and our campaign was called Poop Happens. It was run between July and August of 2023. And these were Facebook and Instagram ads that were targeting parents of childbearing age. And our goal was to reach broadly throughout the province, multilingual audiences, and from all of the different demographic communities that may be harder for us to reach in our traditional ways. An impression is defined as, any time our ad was seen on a digital device by a member of the public, and we served over 1.7 million impressions to men and 2.8 million impressions to women in those 2 months. We also engaged influencers, and this was a way to try to, again, get our message out in a more authentic, personalized way. And through all of this, we were able to drive over 2,300 more website sessions through the social media referrals. So it was pretty successful. And shortly after that campaign came our first biliary atresia case in the province. So this was a little girl, Gwendolyn, in London, Ontario. In the summer of 2023, her parents contacted us saying that their 5-week-old daughter's stool had suddenly become pale. She was brought in for blood work and was admitted to hospital the next day, had investigations, and by 11 days past her presentation, she had the Kasai procedure done. And she is healthy and thriving, and her parents really credit that little paper card to their baby being with us today. So it's working. Some more numbers about our first 2 years. We've had over 600 parents contact the program, and we've looked at over 1,700 pictures of poop. We get, as I said, calls for a variety of reasons, and this pie chart shows that just under 50% of the calls are about pale stool, but you can see a third of them are about other stool colors. So we have learned that there are all the colors of the rainbow that stool can come in, and our card has 3: normal, yellow, orange, and green. And so we get lots of calls about, it's this color which isn't on the card, should I worry? It's not pale, but so a third of the calls are from that. 21% of the calls are from families who are wondering about other stool concerns. It's too often, not often enough, the consistency. And then even 3% are not even about stool. We've referred 84 babies for outpatient bilirubin measurements, and over 80% of our referrals are made within a day of contact with our triage team. The outpatient blood work is completed within 1 to 2 days, and about 20% of our referrals did have cholestasis, met that cutoff criteria. And the bottom right graph is just showing across the 5 academic health science centers what the distribution of referral is. So at CHEO, we saw 3 to 4 cases each year. Population-based, Sick Kids gets the lion's share with about 25 cases a year. So we have diagnosed through the program just under 5 cases of biliary atresia. And that gives us a positive predictive value of 5% for biliary atresia alone, and just over 12% if we include secondary targets as well. And what are those secondary targets? Well, there's still important things that our hepatologists want to hear about: alpha-1 antitrypsin, gallstones, UTIs, biliary sludge, viral gastroenteritis, and idiopathic neonatal cholestasis. And we are very excited to say that even early days, we're seeing a change in our timing of diagnosis. So we have come down from 62 days to 45 days, and our median age of Kasai procedure, 66 days down to 48 days. So not all the cases of biliary atresia in the province came through the program. So these are the cases that came through the program. I mean, there were still cases where, the patient wasn't a candidate for home screening. They were in the NICU, they developed pale stool in the NICU, and they were treated by the team within the hospital. There are cases, there have been cases where families have noticed the pale stool and themselves were convincing themselves that they maybe needed to wait a little bit and presented, without coming through the program. So there's still lots to do to try to educate people about this, and this is one of the reasons why we're so excited for this opportunity to talk today. And as we try to improve the program, we'd like to digitize this. So it is a lot of work looking at all these poop photos. It's very, very subjective. Everybody's smartphones are getting fancier and fancier, and there are a ton of filters that try to make our complexions look not so pale, but it's really interfering with our ability to see the pale stool. And so there are groups around the world that are developing apps for this. One out of Japan, one out of Johns Hopkins, and the group out of Italy named their app the Popo app. And we're in the works right now to negotiate a collaboration with them to get access to their algorithm and do further development of that algorithm and use it within our screening program. It is performing fantastic. It's got great sensitivity and specificity, machine learning based tool, and it can classify acolic, colic, or indeterminate. There's also maybe on the distant horizon a dry blood spot test with this MMP7. So there are studies coming out of Asia now where they have actually developed a dry blood spot assay for MMP7, and the Taiwanese group, who probably having the same issues that we are with the infant stool color card, have actually validated it on their dry blood spot test from their own screening program in the first few days of life, and have shown that it has excellent ability to discern between BA and other cholestatic disorders of liver, as well as non-liver disease patients. So we're now storing all of our dry blood spot samples from babies who had pale stool, and we're hoping to have enough to develop our own assay, a dry blood spot based assay. And finally, we have launched a survey, and this is our attempt to try to understand how much of the public is aware of the program. Are they getting the card? Are they using the card? Because there's no way for us to know. It goes out, but then because we're not collecting them back, we really don't know what the uptake is. So this is a random province-wide survey conducted by a professional organization to both families and healthcare providers, get some information about people's understanding of Newborn Screening Ontario as an organization, our screening programs, and how is it going with the BA screening program. So if any healthcare practitioners are on this rounds, you can go to our website, and there will be a link to the 5-minute survey there. We'd encourage you to fill that out. Also, if you have any families who have kids under 5, you can send them to our website to fill out the survey. So how can you help families screen for biliary atresia? We would hope that anyone who comes in contact with babies under a month of age would reinforce that they have the card and they know how to use it. Encourage them to bring the card with them if they come to see you in your primary care practice or if they come to emerge. And that way, if the concern is solely pale stool, you can direct them to us if it's pale, or you can notify us yourself, and we will expedite that referral to gastroenterology for that direct or conjugated bilirubin. It allows for expert interpretation as well as for us to track the cases in the province. If there's jaundice in your baby that you're seeing, that's lasting longer than 2 to 3 weeks, but they don't have pale still, then you can go ahead and just do that direct or conjugated bilirubin. They don't have to come through us. We're a pale stool program, and so there's the prolonged jaundice, and then that pale stool is the added risk factor for biliary atresia that we want to hear about. But those babies still need, and this is a CPS recommendation, they still need that direct or conjugated bilirubin if they're still jaundiced after 2 weeks. And you too can order a free biliary atresia screening launch kit. You can email us or scan that QR code, and you'll get a starter pack of cards, a desktop holder, some posters, and a script to help educate your staff and families. Our website has a ton of resources. Our card is bilingual, French and English, but we also have it translated in 31 other languages. We would encourage people to not use a printed off version of the card in another language. That's solely to help with the text translation. They really still need to use the physical card for the color interpretation. And on our website, in the BA screening portal, there's more information about the disease, videos on how to screen, frequently asked questions section, how to order supplies, and best practice photo tips, as well as contact forms for parents to submit stool images. So, in summary, biliary atresia is the leading indication for pediatric liver transplantation, and it's a disorder that requires an early diagnosis and treatment for best outcomes, and we need to move the needle on that to give the babies in the province who have this disorder the best chance at a good outcome. Pale stool or jaundice lasting longer than 2 to 3 weeks of age is a potential early sign of biliary atresia. So we need to make sure all babies in the province have this infant stool color card to monitor their stool in the first month of life. And if pale stools is detected, please have them contact us and we'll take it from there and monitor and see if anything else needs to be done. And with that, we'd be happy to take questions.
Are there any questions? I don't know. I saw something in the chat. I don't know if there was something there.
Okay, so there's a question from Dr. Czar. Just as prenatal care has proven its benefit in cost savings, is there a health finance savings case to be made to provincial governments to increase access to 1 month well child visits and universal biliary atresia screening? It's a good point, and we noticed that there was a recent revision of the Rourke baby record. This is the record that is used for guiding well baby checks in the first, I'm going to say 5 years. Looking at Toby. Yeah, I think it's the first 5 years. And there is a 1 month visit there. And I noticed the prior iterations seemed to suggest it was perhaps optional, and now the optional is not there. I don't know what the uptake is in the community for people seeing babies at 1 month, but I mean, there's a lot that can happen at that 1 month visit that is in the preventative care realm that I think would be a cost savings. But to your question, Robert, I don't know of any studies that have actually done that analysis. But I've asked a few pediatricians once I saw that change in the Rourke baby record, and there are pediatricians in the community that are seeing their babies at 1 month as well as 2 months. The problem is we're having families who have a harder and harder time getting a primary care practitioner, and so it's really hard at a population level to have people dialed into a 1 month and unfortunately even a 2 month visit now.
Thank you. I appreciate that.
Super good question.
Where are patients directed for blood work for positive screening? So it depends. So the question is where the patients are sent for blood work. So if they come through the newborn screening program, we hepatologists at different healthcare centers get contacted, so we take care of that. So some people, let's say somebody lives in North Bay, we have forms that we fill out and I send it to that particular lab, so they're done at that location and I get the results the same day or after. If they're in the city, they come to CHEO, for example, and I enter orders on the CHEO lab. So that's what they're done. Like if it's done outside of the program, the primary care provider can do the blood work anywhere where they are located, and they can then reach out to either NSO or the GI clinic. Yeah. Toby?
I just need to follow up for Robert's question, and thanks both of you for the amazing talk, and congratulations to you and the team on the amazing work with the really impressive outcomes and a really neat approach to working with the community and multimedia, AI, all of that. You alluded to Japan, I think you said, or maybe it was Taiwan, having some kind of like, this stool card was in some kind of like handbook or something like that, which made me wonder, like similar to Robert's question, like what are the other things that could be bundled with the stool card dissemination network that might be things we're screening for that would lend themselves well to a AI learning or other type of thing to support patients and families. And so did you happen to, in working on this, look at what other things are in that Japanese mother-baby handbook or whatever you called it? Yeah.
Just repeat that.
Yeah. So the question is, the Japanese and Taiwan programs have incorporated this card into a mother-baby handbook, and have we looked at what else is in there, and are there any clues there that we could use to try to incorporate this into a similar thing here? And yes, so there's anticipatory guidance in there, stuff about nutrition and growth development. And in the development of an app, we would have this app not just be for biliary atresia. So we know that people aren't going to, there won't be a big uptake for an app that only has relevance for 1 month. So the idea would be to have this app have a multi-function, and we've been in discussion with Can Immunize, with Born, to try to see whether we can tie in some other important features for families, and not just the biliary atresia screening. So it's a great question.
Maybe you need to talk to the work.
Yeah, I have talked to the Rourke people. So yeah, so we also talked to the Rourke people and asked on their next iteration to add a reference about our screening program for the Ontario folks.
Think about primary care capacity. We want the primary care in-person visits to focus on the stuff that we couldn't do in another way, right? And so what are the things that, like this, like parents can clearly use the app, do their own poop card, whatever it is, and then only see babies that need blood tests, right?
Right.
So what, maybe there's other things out there that parents would be empowered to triage themselves. It's really interesting concept. All of the other things all the other questions parents bring to us when the baby's 1 month old.
Yeah, oh, it's a great point, Toby. And maybe as we're developing that app, we'll hit you up for some ideas of what else could go in there. You or other people that are taking your.
Yeah.
Be able to, our primary care partners, the ones who would be able to tell you, the community pediatricians too, I'm sure they would have great ideas about what shows up at their door routinely.
Yeah, good point.
Okay, she has a question.
Oh, yeah.
Well, question. Is there a way, or was it considered for NSO to order the conjugated bilirubin instead of sending hepatology? Like, would that decrease the time by 1 day, maybe?
I would say, so the question is whether NSO could directly order the blood test and instead of waiting for the hepatologist. So we have a system that we have a direct communication, because I think their role in NSO is to identify the positive screening patients and then pass it on, and not to interpret or decide, because then the results will come to them, and then what they're going to do, they're going to do the same thing. So I don't know in what capacity to order blood tests, because Erika is kind of the lead in certain areas, but she won't be able to order all the blood tests. So there's nurse practitioners, for example, in Toronto that are the key people that NSO contacts. In all the other centers, all liver doctors are 100% into this, because we've been looking over many years to have this done. We're kind of behind in terms of worldwide, and in Canada, now we're the second province that has it. And there are other provinces like the Maritimes and other provinces that are kind of getting into doing it. So we want a whole Canada screening program, and that's what we're aiming for. So yeah, we still need that connection with the liver specialist so that, we order it. Sure.
Liability for the retrieval center and pathologist ordering the blood work on a patient they have not blood.
So the question is if it's a liability for us ordering physicians, ordering this blood test in patients that we haven't met. So I haven't.
Consult.
It's basically a consult. It's, even though we haven't seen the child, we kind of interpret the consultation, and this is the next step, which we often do. Like on e-consultation, you do e-consultation and you don't see the child. You just base your assessment on what you get on the consult. So, we follow up, and sometimes I see them in clinic and the next day or the same day. So because we're advocating for these patients, because we follow them before transplant, post-transplant. We want to do this as soon as possible, right? Yeah. And Mark, I see your question here. We do have the cards on the ward, and actually for the people present here, I'm going to show you, this is very cool because I got this present from Margot. This is a pen that actually has a poop card that, I don't know if you guys can see it. And for people present here, we have it at the back. So on your way out, please get your pen. And we do have the infant stool color card at the back, so for people to see. But I do think that it's been distributed to all the wards, NICU. We have it in some clinics, and this has been promoted everywhere. As Erika mentioned, we're trying to implement more dissemination and distribution of the cards. Yeah.
And I think we're at time, but just to answer Pauline Kerr's question about did the 5-week-old have acolic stool from birth? No. So a lot of these babies will have some pigmentation. As we know, they come out with the black tarry meconium. And, this is a progressive obliteration. And so the timing of the obliteration is different with every baby. And so there's sometimes a little bit of bile pigment that's still happening. And we have seen babies who have on and off a little bit of pigmentation come back, but this child had pigmented stools that suddenly became acolic. And so any concern about pallor doesn't have to be chalky white. If it's less pale than usual, keep a closer eye on it. And if there's any concern, give us a call. So I think we'll end it at that. Thanks for all the great questions. And you can hit our website or contact any of us from the team if you have any other questions or want to talk about a case.
Thank you.